Welcome and thanks for joining us on the Flourishing Life podcast, where we will be discussing what we see on the daily. We're Jackie and Tad from Flourish Medical and Wellness in Savage, Minnesota, where listening to our patients is the priority. Our foundational medicine clinic bridges the gap between traditional and functional medicine. We are pattern recognition specialists that focus on individualized patient care and health optimization. With a combined 30 years of medical experience, our goal is to provide insights that will help you take control of your health. Be sure to follow us on Instagram at Flourish Medical Wellness and on our website, flourishmedicalwellness.com, to stay up to date with what's happening at the clinic. The following content is the opinion of Jackie and Tad Tewes and is not intended to diagnose or treat any medical conditions. Please be sure to speak to your healthcare provider for your unique needs. Hello, everyone. Welcome back to the Flourishing Life podcast. This is Tad and Jackie from Flourish Medical and Wellness, where our priority is listening to you, our patients, and practicing a team approach to foundational medicine for long-term healing. This month, October, is Breast Cancer Awareness Month, and we have had the privilege of working with many breast cancer survivors, maybe one of my favorite patients to work with, just because we're really able to provide some hope and so much better quality of life. A lot of women really suffer after going through breast cancer and breast cancer treatment, so pretty cool that we get to walk through that with them. So we're excited to be doing this and hopefully to be able to shed some light on this for everyone else out there who might be walking this journey. And so, Tad, tell us a little bit about statistics behind breast cancer, the rates here in America, what that looks like.
Yeah, and for this discussion, obviously we're talking about breast cancer in women. Now, breast cancer in men is possible, extremely rare, but breast cancer in women is the important piece because it's the most common cancer in women. About 1 in 8 women are going to develop breast cancer in their lifetime, so think around 12-ish%. And it's something where we're seeing statistically breast cancer rates rise by about 1% per year. And that's since the early 2000s. We're even seeing a faster rise in premenopausal women, so think women in their 30s and 40s. And not only understanding what is causing breast cancer, what's causing these increases in breast cancer, but also what role do hormones play in this too. And then the other piece behind this is, like you had said, Breast Cancer Awareness Month is awesome because that diagnosis of breast cancer and then the subsequent treatment, it's really a sentinel period of time for a lot of women. And then for breast cancer survivors, breast cancer survivor women, what does life look like after that? And how can we optimize quality of life? I think that is a monstrous question that modern medicine has not done an adequate job with addressing. And so that's why people like you and me are here. But beyond that, so why is this important for breast cancer? The average age is the lower 60s time period. 62 years of age, I believe, is the average age, just based on all the women diagnosed with breast cancer within the United States. And a woman is diagnosed with breast cancer every 2 minutes here. So it's an important topic to talk about. But can you talk a little bit about the hormonal side of breast cancer? Not only some of the physiology about how the way the female body functions, but also digging into a little bit some of the misrepresentation of hormones and how we look at hormones too.
Yeah, so the pathophysiology is not always very fun for everyone, but I do think it's really important to understand that. And I'm going to try and just speak very high level with regard to that. So when we think about breast cancer, we really think about 3 main hormones. We think about estrogen, or different types of estrogens, progesterone, and then testosterone. So you can have an estrogen and or progesterone positive breast cancer. They play a role in breast cancers. So we're going to break down what that means, okay? First, important to understand, when we talk about estrogen specifically, there are 3 types of estrogen. We have estradiol, we have estriol, and we have estrone. And so these are different, very different. We make the most estradiol, we make very little estriol, and then we have some estrone. This matters in how they're binding to that receptor. So what is a receptor? A hormone receptor is where that hormone attaches to or docks up to, basically, and it has to do that to create its function. If it doesn't bind or attach to that receptor, the things that it's supposed to do don't happen. So they have to bind to the receptors. Now, when we're talking about estrogen receptors, we have estrogen receptor alphas and betas. Alphas are, think awful, okay? Alpha, awful. These are bad receptors. We don't want to be binding up to a lot of alpha receptors because that is what we see with breast cancer. When we think about beta receptors, think these are better, these are best, these are good, these are protective. And so estradiol, again, what we make the most of, binds equally to our estrogen alpha and our estrogen beta receptors. So across the board, an even effect. There's no outcome one way or the other, more alpha or more beta. It's even. Estriol, which again we don't make a lot of, binds primarily to those beta cells, so protective cells. That's great. That's a good thing. And then estrone actually has about 5 times higher affinity for the alpha receptors. This is not good. This is a bad thing. This is where we see estrogen positive breast cancers, and we have to remember that's the alpha receptor. So that's the bad one. That's why you sometimes hear estrone being called the bad estrogen.
Yeah.
And that is why. It's important to understand that estrone is made and primarily stored in our adipose tissue, our fat tissue, or adipocytes. And so that is one of the reasons why obesity presents with a higher risk of breast cancer. If we have higher adipose or fat tissue, we have obesity, we have a higher risk of breast cancer. And that's pretty well known. And that's the reason behind that. The other thing we need to understand about this is that specific types of estrogens, as far as an estrogen replacement, that are out on the market, like conjugated equine estrogen or Premarin, that has higher levels of estrone. And so again, that can activate more of those alpha, those bad receptors, and therefore increasing potentially that risk of breast cancer with higher estrones.
Yeah. And you're referring specifically to breast tissue, correct?
Breast tissue, correct. Okay, then we have progesterone. And again, we have alpha and beta receptors when it comes to progesterone. Your normal healthy breast tissue has more of those beta receptors. And what we see in those women with cancerous breast tissue, we're seeing more of those alpha receptors. So it mutates and we're seeing more of those alpha receptors. When we talk about hormone replacement therapy, micronized progesterone is going to predominantly bind to our beta receptors. So we're not seeing an increase of that alpha receptor. So that's important, again, important to understand.
Can you explain what is micronized progesterone?
Micronized progesterone is the type, well, it's a smaller molecule, that's the micro piece of it, but it's the bioidentical progesterone that our body makes. And so it's exactly what our body makes naturally in that chemical structure versus a synthetic, like a progestin is synthetic. That chemical structure is different. So the binding is different. So we don't see the exact effects happening when we're using synthetic hormones because they're not binding exactly like our natural hormones or our bioidentical hormones.
Yeah, and I think that's a really important point to make is just when we use synthetic hormones molecularly and at the cellular level, there can be differences compared to a perfect progesterone molecule that a female makes normally.
For sure. So the other thing to understand that we know is that progestins, so synthetic progesterones, actually bind to, can have some affinity for our androgen receptors, so testosterone receptors. And this is important to understand because, which I'll get into next, testosterone or androgens actually have an anti-neoplastic or protective effect on the breast when it comes to breast cancer. And so if our progestins are blocking our androgen receptors, we're losing out on the protective benefit of our androgens because it's being blocked up by that progestin.
You made a good point earlier in that for a receptor, it has to have that androgen, like testosterone, bind to the receptor, and that complex is what leads to all of those positive metabolic benefits downstream, whereas the progestin binding to the androgen receptor will not lead to those outcomes.
Correct. Okay, then we have testosterone or androgen receptors. Again, androgens we know have an anti-neoplastic effect or an anti-proliferative effect. meaning it is going to help prevent the growth of breast cancers or those cells, and it's going to help to kill off the bad cells. Okay. And those are obviously binding to the androgen receptors. And so one of the other important things to know is that there's something called BCL2. This is a protein that controls whether or not a cell lives or a cell dies. And so when we have higher amounts of this protein, cancer cells can live and proliferate more quickly. So we don't want to have too much of this protein. And androgen, so testosterone specifically, actually lowers the amount of BCL2 in our tissues. So again, protective. That's one of the protective ways that it works. When we do have some literature around this, and I'll dive into that more specifically, but just very quickly here, we have seen several studies. Dr. Glaser, the Maritas, I believe is how you pronounce that, in 2013, Bondi in 2009. So what these studies found and what these researchers were looking at were testosterone and breast cancer. And so testosterone with or without anastrozole in the pellet form, so subcutaneous implanted under the skin, actually reduced the incidence of breast cancer in pre- and postmenopausal women. And that was the Maritas 2013 study. Now, anastrozole is an estrogen blocker. So think we're blocking that estrone, but allowing to have the positive benefits of testosterone, which is great. That's what we want. Dr. Glaser, we've talked about her work before, pretty incredible. She's treated many women with breast cancer using androgen therapy around the tumors, so inserting pellets around those tumors. Specifically in 2019, she published a study that was a 10-year study. They looked at over 1,200 women, and what they found was that testosterone pellets had no increased risk of invasive breast cancers. That's what they were looking for. Was there any increased risk of cancer in these women being given testosterone? And it was not. And then that final study showed us that androgens inhibit mammary epithelial proliferation and growth. So again, that's where that testosterone really helps stop that proliferation and is anti-neoplastic.
Yeah, and that's such a big deal too when we're looking at cell proliferation, because if we do have things that we introduce into the body that would cause an increase in epithelial growth or even atypical growth, we typically see cancer growth increase or cancer incidence increase downstream. So that's a really important point.
Yeah. So that is how hormones in breast cancer, kind of the pathophysiology, how those things are working. Can you tell us a little bit about why, up until now, why have we kind of thought or been told to believe, been made to believe that hormones are bad, estrogen causes breast cancer, and we shouldn't be using them? How did that all start?
Yeah, and it's interesting because when we look at American history, it wasn't always this way. Up until the early 2000s, we had about a third of postmenopausal women who were using hormone therapy, hormone replacement therapy, for not only improvement in quality of life, but increased bone density, decreased risk of dementia, all the positive things or the health preserving things that we see with estrogen. And then we had the WHI study come in. A large study, 20,000 women, and it was two different arms to the study, and that began in 1998. So we had in arm one, we had estrogen plus progestin, which is a synthetic progesterone, not one that is natively made by women, versus a placebo group, or a group receiving no hormones. And then in the second arm, we just had estrogen versus a placebo group. And what they found was they ran the study for about 4 years. In 2002, they shut off the study, or they stopped the study because of risk concerns. And with that first group, the estrogen plus the progestin, they found a small increased risk for breast cancer. In the placebo group, or the group receiving no hormones, it was 4 out of 1,000 women who developed breast cancer. And then in the hormone group, which was estrogen and progestin, they found it was 5 out of 1,000. So an increase of 0.08% is what it came out to be. The nasty part and the misrepresenting part was that when the media came out and presented this to women, they presented it as a 25% relative risk increase, going from 4 to 5 out of 1,000. Yeah. So a statistically insignificant change turned into holy cow, that is a giant increased risk. I better stay away from hormones or I will get cancer. And so it led to a huge whipsaw effect. Women in mass numbers stopping hormone therapy, providers, medical providers refusing to even use hormone therapy for concerns about risk and concerns about medical legal ramifications too. And then in the second group, which was just the CEE or conjugated equine estrogen derived from horse urine, they found a small increased risk in blood clots. And what we know now is that was more delivery method than anything. It was an oral estrogen. And what we know is that oral estrogens can increase risk for blood clots in women, whereas estrogen that is given either through the skin with, let's say, a patch or a cream, or getting subcutaneously with a pellet will not increase risk for blood clots. So delivery method matters. And we have a whole mountain of studies to back that up now. But what it led to was when they shut off those studies in 2002, there was a mass scare, and you had basically a whole generation of women who was led to believe that hormones were bad. They were either going to cause you blood clots or cancer. And that's the way it was presented to the media, which was really a disservice to women in the United States. And you also had providers who really whipsawed their opinions, and it led to a whole generation of providers who were trained in the early 2000s saying, hey, hormones, hands off. I can't put my hands in there. I'm going to get sued. This is risky. I can't do that.
Yeah. So a couple of things. So to kind of break that oral estrogen down a little bit more, the reason for that is that when you take oral estrogen, it goes to the liver.
Yep.
And the liver is also where our clotting factors are made. So if we're bypassing the liver, we don't see that. So that's the connection there. We are still seeing this. Literally yesterday, I got a portal message from a patient who had seen her gynecologist. And I'm just going to say this. I think if anyone should be well educated on hormones, it should be our women's health specialists. And those are gynecologists. And so she had messaged me saying that her gynecologist told her she needed to stop her hormone therapy because she was concerned about blood clot risk and that it was making her cholesterol go up. Her cholesterol was like, her LDL was like 120.
Okay.
So that's not even high, but that's a whole other point. And so to me, it puts me in a bad place, right? Because I never want to tell a patient that your provider is just not telling you the truth or speak negatively really about other providers, because I think they mean well. I don't think that they're purposefully and intentionally trying to spread misinformation. I would hope not, right? But they just don't know. And so then here we are stuck with, okay, well, this isn't true. Unfortunately, you've been given wrong information. Here is the truth. And so, it's hard to talk through this with patients when someone that they think they trust and they should be able to trust because they have a certain title behind their name isn't staying well educated and up to date with the current literature.
Yeah, and it is a challenging and uncomfortable situation. Both you and I have dealt with that numerous times, but being able to take time, go through the physiology of hormones with women and an understanding of here's the literature that shows these effects with estradiol, with progesterone, with testosterone for women specifically. And then also here were the apparent risks that came out in the WHI study. And here's all of the studies that have debunked those findings. Also, they came out, I think it was either 2017 or 2018, where they reviewed back to that study and they followed these women and said, okay, was there an increased risk in cancer? No, not in the long-term studies at all. And there was no increased risk in all-cause mortality at all. So what we're seeing
I think they actually found protective benefits or lower risk of breast cancer in the hormone-treated group.
Correct. And that's where what we're seeing is as we get higher quality studies, and numerous researchers have looked at that study from the WHI and said, this is such a flawed study. It really was a study that led to such a change in how the American public and providers viewed hormones, and it was all flawed data and really flawed representation of that data too.
So I think the takeaway from this is that unfortunately, especially medical, like there's probably not enough of us to go around, to be honest, across all of the United States. We're putting in long hours usually for the most part, and we don't have a lot of time always to update our education and research. And so I do think it's important for patients to understand, hey, I might need to advocate for myself, and I might need to say, well, what about this? I thought the research showed that this actually had a lower risk of breast cancer, and it's okay. It's okay to challenge that provider. I welcome that. I love when patients challenge me and say, hey, well, I heard this, so what does that mean? I love that. I welcome that. Please do that. And I think our patients need to get a little more comfortable doing that with their providers as well, just saying, well, what about this? How did this really play out? This is what I'm hearing. And if they don't know, hopefully they'll just tell you, well, I didn't hear that. I don't know that. I'm not up to date with that. That'd be great. The other thing that I think we have in our favor is that there is some talk about the FDA removing that black box warning for estrogen for clots and breast cancer, which I think will be huge. I think it'll force providers to start to say, wait, okay, maybe this is okay. They might not still know all the nuances and kind of the details around that, but I think it's a step in the right direction, and hopefully it'll at least start to get some minds thinking on that a little bit. Because when we look back at that study, the whole reason they did this study was because they were seeing how beneficial it was. It was reducing colon cancer rates and osteoporosis rates and cognitive, like it was helping women. That's why they went on it to begin with. And even in the study, we saw improvements in that. So it's like they took these false kind of elevated concerns, completely ignored all the other good stuff that it actually did, and really focused on these two things that weren't even statistically significant.
Absolutely. And that's, you make really good points in there. I think if I could leave the people listening to this podcast episode, if I could leave them with anything, and you have a ton of data to go over and some incredible information, the biggest takeaway I would have people leave with is ask good questions, do your own research, be an advocate for yourself, because what it will do, not only will it help that individual understand health and the things they need to be considering, not only for short-term health, but also long-term health and wellness, but asking a provider those questions, it makes providers research more and be better.
Absolutely.
And the problem is we're not seeing the health outcomes getting better long-term in this country. So we have all the technology in the world. We have access to information better than any time in American history, but the health outcomes are getting worse. So we need to have providers change what they're doing. We need to have patients advocate for themselves and utilize that information. And that's when we're going to raise the tide and all ships are going to start rising.
Yeah, for sure.
And then to circle back to risk, one thing that is important to point out. So the Journal of the National Cancer Institute back in 2001 took a look at breast cancer specifically, and they were looking at breast cancer recurrence. What they found was per 1,000 women, they found a 17 out of 1,000 person years breast cancer recurrence in hormone therapy using women, so 17 out of 1,000, whereas in non-users, that recurrence was 30 out of 1,000,
Wow.
almost doubling the risk of recurrence. They also looked at mortality rates in these women. So in women using hormone replacement therapy, there was a 5 per 1,000 person years risk for mortality, whereas that was tripled in non-hormone replacement therapy women, 15 per 1,000. Again, speaking to some of the protective effects, not only for cancer, but in other areas of the body, like heart disease. So huge findings. Those findings were replicated in a Finnish study done later. That study was a 15-year observational study with very similar protective effects that were just replicated compared to the Journal of the National Cancer Institute results as well. But what other studies did you want to share with people today?
Yeah, so I'm going to grab them so that I don't misspeak on any of the information here. But there are just 3 that I want to touch on. There's more than this, but just building that supporting evidence. And I'll put these in the show notes too, so that you guys, if you want to pull that when you're talking with maybe your oncologist or your primary care provider or your gynecologist, especially when it comes to the breast cancer piece, that's here for you. So Dr. Donovitz, this was published back in 2021 in the European Journal of Breast Health. And what they looked at, they were investigating the incidence of invasive breast cancer in pre and postmenopausal women treated with testosterone therapy and then testosterone in combination with estradiol. And they were comparing these to that kind of baseline establishment of how many women out per 1,000 get breast cancer. So that was their comparison. So women on hormones, the incidence was 144 versus 223 on women's not on women not on hormones. And then when we look at the WHI study, that rate was women not using hormone replacement therapy was 330. So again, 144 cases versus 330 cases. The other important takeaway from this study is that it was done with looking at pellet therapy specifically, so that's subcutaneous implant. And at the time of publishing of this study, what the author reports is that at this time, no other route of delivery for testosterone has demonstrated a reduction in the incidence of invasive breast cancer. So that means that the topical or transdermal application of testosterone, we can't apply those same findings when we're using the topical route versus the pellet route. This was just specifically looking at pellet therapy and subcutaneous therapy. That's one of the reasons here that we like pellet therapy. It is very easy to control if you know what you're doing and to understand. And we see it can have this is a great benefit from that, is having protective benefits for the breast versus that oral or transdermal. We just don't see the same improvements there.
Absolutely. And you and I talk a lot about consistency of blood levels of both estrogen or estradiol and testosterone. And that's where we see such a difference in terms of that subcutaneous therapy versus a topical therapy, is the consistency there.
Yeah. The other study with Dr. Glazier, she was comparing the rates, and she also used the subcutaneous testosterone therapy. And what she found was 142 cases in the hormone replacement therapy group, again, compared to that 293 or the 300 in the WHI study that weren't on hormones.
Wow.
So again, this is just showing that there's less cancer development in women who have been given testosterone, estrogen. Like, it is better than those not having hormone therapy.
Do you think that that's one of the reasons why we see the highest incidence for breast cancer in postmenopausal women? Not to put you on.
That's a great question. And, it goes back to, we know that what we tend to see is that women who have never been pregnant tend to have a little bit higher risk of breast cancer. And so why is that? When we're pregnant, our estrogen is 100 of crazy high estrogen levels. And so, yes, we know because of the pathophysiology that testosterone is anti-neoplastic. I think, we don't know this for sure, there hasn't been a study to specifically back this up. But when you gather all this and cumulatively think about these things, right? Like, it's most common postmenopausally. And it's most common in women who don't have children because they've never had higher estrogen levels. What if estrogen is actually protective?
Well, it's certainly protective in other areas of the body.
Right? And that's what, in this whole time, the last 20 years, we've been thinking of it the opposite. Maybe that's also part of why our breast cancer rates are increasing every year, because we've had these generations of women who were kept from having hormones, and now we're seeing this rise of breast cancer. Like, I think there's something there that we don't quite know exactly yet, but I do think that there's some protective benefits of estrogen and estradiol on breast and breast cancer prevention. Okay, the final one, really quick. This was, again, Dr. Glazier. She was looking at tumor size. So these were the women that she had implanted, again, subcutaneous testosterone pellet around the breast cancer tumor. So by day 46, there was a 7-fold reduction in tumor volume.
Wow.
Okay, this is measured by ultrasound. And then by week 13, there was a 12-fold reduction in tumor volume. That's a lot.
That's incredible.
So pretty cool that she, has done so much work around this. And again, it just speaks volumes. Like there's no other way to explain that. This was the testosterone pellet directly against the tumor, shrinking the tumor. Testosterone is anti-neoplastic. Like it helps prevent and shrink breast cancer tumors.
And it's pretty amazing. Most providers would never be bold enough to do a study like that. I mean, a handful of providers in this country. And so when you look at some of that groundbreaking work that Becky Glazer has done, it's incredible. And she's really going to bat for women, specifically in the area of breast cancer and understanding the hormonal effects of breast cancer for those women who have been diagnosed.
Yeah. So again, key takeaway. There is literature, there are studies. I'll link these, but if you are a current breast cancer patient or a previous breast cancer patient, and not only does testosterone help prevent and protect and reduce tumors, it helps with sleep, moods, energy, motivation, sex life, cognitive function. Like these are the areas that women are suffering with after breast cancer because they've been all of their hormones have been taken away. So estrogen's still controversial. Fine, I'll leave that alone. But you can use testosterone and you can get your quality of life back. You don't have to live with all of those things. And we also see improvements in cardiovascular health and your cognitive function, Alzheimer's, dementia, and bones with testosterone as well. So it is not this life sentence of having to live that way. If you currently have breast cancer or if you had breast cancer, testosterone is a very safe option for you. And so take this information. You don't have to know all the ins and outs. Just start asking questions and go to bat for yourself, advocate for yourself.
Yep, absolutely.
Okay, so I'm not going to get too far into the weeds. There's a lot more out there, but I think those are kind of some big key takeaways. So if it's not these hormones that we've kind of been made to believe cause breast cancer, what increases our risk of breast cancer?
We'll see genetic factors influencing breast cancer, and that's going to be around 5 to 10%. But for the most part, we're seeing most breast cancer pop up in women who are not necessarily genetically predisposed or have a high genetic risk factor for breast cancer development. Like you had said, never having children is a risk factor and is a question of, does the absence of those high estradiol levels lead to breast cancer? We don't know yet. We just know that not having children does cause an increased risk for breast cancer. And then alcohol is another very common one. One drink per day increases risk up to about 10%. 3+ drinks per day will increase risk by over 50%.
That is a lot.
Yeah.
And this is also something that pushes my buttons because these women that come in are like, oh, my doctors told me I shouldn't be on estrogen because it's going to give me breast cancer. Did they talk to you about alcohol?
Yeah.
Did they talk to you about exercise? Those are a significant risk increase, but we're not educating on that.
Yeah.
So 50% increase, you said?
Yeah.
With 3 drinks or more a day?
Correct. Yeah, 3 or more per day is really where that threshold jumps up significantly.
Wow.
Yeah. And the other thing we look at too is toxin exposure. And we're all living in a toxic soup for the most part in terms of air quality, the foods that we eat, and we have to be very careful about that. Hygiene products too, topicals, makeup. When we look at common toxins, phenols are going to be a very common type of toxin. We're going to see that in laundry detergents, dish detergents, pesticides. Parabens, very, very common in cosmetics. So that's one that women really need to watch out for as a hormone disruptor.
And you'll see that on your ingredient list. It'll say like ethyl paraben or butyl paraben. So you can look for those.
Yeah.
specifically?
Absolutely. VOCs or volatile organic compounds, we're going to see those mostly in like tobacco smoke, plastics. Plastics is a big one. Some food packagings, candles, perfumes, pesticides. Those are a big one.
Candles and perfume. Sorry, I talk with women about them all the time. Like, it's a huge one. And again, it's so well accepted. No one ever tells you that you shouldn't. But if you think about the daily exposure, like, it adds up. On average, women put on 168 unique chemicals on their body every single day. 168. That's not even what we're breathing in. So eventually this adds up, and the endocrine disruption and things like breast cancer it's real. It's a real concern.
Absolutely. And then obesity too, like you had talked about, as there's an increased risk in adipose tissue or fatty tissue, that will lead to changes not only in terms of hormone production, but also then the expression that occurs with those different forms of estrogen, specifically estrone. Another important piece to talk about also is statins. So when we think about statins, for the most part, people are thinking about heart disease risk. That's why we like to see the lower cholesterol numbers, or traditionally that's something that we've looked at. So understanding the value of cholesterol in the human body is the basis for this. And cholesterol, as you know, is a building block. It is building material. We're making cell membranes. We're making hormones with this. So as we decrease the amount of cholesterol with a synthetic substance like a statin, it is going to affect those downstream metabolic processes within the body. There was a study that was done looking specifically at cholesterol and a couple different types of breast cancer. This was from women aged 55 through 74 using statins for 10 years. In this study, we saw an 83% increased risk for invasive ductal carcinoma, a type of breast cancer, and then a 97% increased risk for invasive lobular carcinoma. So these aren't small numbers.
That is a lot.
It is. And this is where, when we utilize medications, especially medications that are considered the standard of care, like statins,
So statins are going to be simvastatin, atirvastatin, rosuvastatin, just for clarity so that they understand.
Correct. Yeah. So medications designed to lower cholesterol. Providers just need to be mindful that there can be some effects, some negative effects or side effects, and also they can be gender specific. This is talking about breast cancer. We know that the incidence of breast cancer is infinitely higher in females than it is in males. And so understanding that there can be some downstream effects because of how it affects cholesterol metabolism in women. And that there's a risk-benefit analysis that needs to occur there. So will you talk about screening recommendations and different options for women, especially when it pertains to breast cancer?
Yeah, so this is another, I think, controversial topic. And unfortunately, I would say there's no perfect screening out there currently for breast cancer. The current guidelines, the USPSTF current recommendations, are that women between ages of 40 and 74 receive a mammogram every 2 years. Now, if there's findings, that might increase, but that's the current guideline. So when we look at mammograms, there's different types of mammograms. There's a 2D mammogram, there's a 3D mammogram. 2D mammograms are going to be more of those traditional mammograms, a little bit less radiation, but we tend to see a little bit higher false positives, so they're not quite as accurate, as well as some false negatives. And then, oftentimes when we see this, if there's an abnormal finding, then that leads to an ultrasound, and then that leads to a biopsy of the tissue. And what we found was that we're biopsying a lot more tissue than what we need to be. And so again, it's not perfect. Then we have our 3Ds, which they're going to be a little more accurate. You're going to get a little bit clearer picture, which is great, but you also are going to have some higher radiation. There is some concern out there that more radiation to the tissue, more trauma to the tissue can actually potentially increase risk of breast cancer. And so again, kind of weighing the pros and the cons there. Then there's something called thermography. This is an infrared camera that is used to basically take photos of the breast tissue, and it's looking at flow. So think mammograms are looking at structure. thermographies are looking at flow. If we have an active tumor or an active cancer, it has to be being fed. There has to be blood flow to those cells, those tumor cells, for them to be growing, for replicating, and making more. So that's looking at the flow versus the structure. There is no radiation with this, so it's a little bit safer. There's no trauma to the breast tissue. It's just photos. I would say this is helpful in women who have denser breast tissue, just because we can see, it's really hard to see when we're looking at the structure with the mammogram. It's hard to see some of these microcalcifications or micro cancers that are starting when their tissue is super dense. So if you are somebody who has more dense breast tissue, a thermography might be a good option for that. Instead, you do not need an order for this from a provider. You can just call up and get one done. And then also, this is a little newer, it's something called the HER scan. They will go around the different areas and set up shop and do it. And this is just an ultrasound of the breast. So again, no radiation. It's going to look at, again, the structures that are there. Because remember, we do the mammogram and then typically we'll do an ultrasound and follow up. So it's just kind of skipping the mammogram piece and going straight to that ultrasound. So limitations, it's not great at microcalcification. So again, those are very, very small cells, but it does increase cancer detection, I think, back to about 96% compared to a mammogram. Unfortunately, this isn't necessarily covered by insurance, so it's going to be somewhere around about $200, $300 for that. And again, you don't need a referral for that. So I talk with women about this all the time. They're like, what do? I don't like mammograms. They're uncomfortable. Like, do I keep doing these? I'm worried about the risk with this. So there's different options. I do recommend that you do something to stay on top of that, and also take into consideration what your family history is or your personal history. And so it's not a one size fits all, right? If you have super dense breasts, think about a thermography. If you have, it's really painful and you've had a lot of radiation exposure, maybe an ultrasound is better. So it really needs to be individualized for each patient. But those are kind of the different methods of testing that we currently have. The other big thing, I think, is just prevention, right? Like, why don't drink alcohol? If you do, minimal, right? Like, it doesn't need to be a daily occurrence. Exercising, moving your body, trying to get down some of that fat or that adipose tissue is so important. Scanning your products. There are so many apps out there, EWG, Skin Deep, Yaka, like there's so many apps now that you can scan your products with and find out, do these have high levels of those endocrine disruptors that are going to put me at increased risk of breast cancer? So there's absolutely things that you can do to help mitigate that risk. And then those are kind of the different screening methods that we have.
Will you touch on quickly best practice for self-breast exams?
Yeah, so there's some controversy here. When I was back in the lineup, they kind of said stop doing breast exams as the provider on a patient because they're pretty subjective. However, I think if you are doing one consistently every single month, you're going to become familiar with your own breast tissue. And so more importantly, you're going to find if there's something different, you should hopefully be able to notice that. And so really the important pieces there are doing it at the same time every month. Maybe it's a week before or a week after your cycle, because we do have some tissue changes based on our fluctuating hormone levels within our menstrual cycle. So kind of picking, hey, I'm going to do this 1 week after my period every single time. It should be pretty similar. And then just simply, palpating the bare skin around both breast tissue. Can be up and down, it can be side to side, it can be in circles, whatever you need to do. But just gently palpating, touching that breast tissue, and making sure you're getting the whole tissue even up into the armpit, because we have breast tissue up in the armpit. And if we're consistent with that, usually you can pick up on some changes if you're seeing that. Your husband would probably want to help you with that too.
So big takeaways, once a month and at the same time in relation to your cycle.
Yeah.
For women. Perfect.
Yeah.
This is a really, really important area of women's health, and something that we are finally starting to crack open the door more in terms of hormones, especially breast cancer survivor hormone use, which is a long, detailed conversation that we have with women who have been through breast cancer. But any final thoughts for people listening?
I think, key takeaways. Number one, hormones do not cause breast cancer. What causes breast cancer increases that risk. Maybe some genetics, but more so a lot of lifestyle things, alcohol, weight, lack of exercise, and then our environmental toxins. Those are much more significant and much more of a risk. And then treatment, what are my options? And then how do I look for what's the best test for me? And then what are my options if I've had breast cancer? What are the options that I have to live and have a quality life? And there are options. You just have to find the right providers who are willing to work with you and educate yourself. That's so important because you have to be able to advocate for yourself. And then please share this if there's somebody in your life who is going through breast cancer or has been and they're miserable. Please share this with them. There are really good providers, not just us who do this. Like, there are a lot of good providers out there that will help your family member or your friend who is experiencing this, because they might not be getting all of the accurate, up-to-date information from their current providers.
Absolutely.
So share it with them.
Wonderful.
All right, next, are we good?
We are good.
Okay, next month we are talking about labs. Your labs are normal. We've talked about that a couple of times. We're going to expand on that. And then the other thing we haven't really talked a lot about is going to be different functional medicine tests that we potentially use, or that we've seen other, seen patients come to us with. And sometimes you have to be careful with that a little bit, because sometimes we can over-test, sometimes we can under-test, but it's important to get the right test that is actually giving us good quality information. So not all tests are created equal. We're going to dive into that a little bit. So thanks for joining us today, and reach out if you have questions or if there's any other topics you want us to cover.
Have a great week, everyone.
Bye.
Thanks for listening in to the Flourishing Life podcast. You can watch this full video version of this podcast inside the Spotify app or on our YouTube channel. If you like this episode, please rate, review, and subscribe on your favorite podcast app. And be sure to share this episode with a friend. And follow us on socials at Flourish Medical Wellness and on our website at flourishmedicalwellness.com. The information on this podcast is for educational purposes only and is not intended to replace medical advice or to be a substitute for professional medical diagnosis or treatment.